It's always a pleasure to come to Ireland. The Guinness is better over here, and the rain is of a better quality as well. So, without further ado, I'll start with this picture of Dr. Melvin Ramsey, who is one of the key figures in the history of ME, chronic fatigue syndrome. It was he who was a consultant at the Royal Free Hospital in infectious diseases at the Royal Free Hospital in the 1950s, and it was he who described the outbreak of ME, which occurred amongst nearly 300 members of the medical and nursing staff there, between July and September 1955. And it was he also who coined the term myalgic encephalomyelitis. And since then, it's apparent that there are in fact other cases of such outbreaks elsewhere in the world. But he was instrumental in generating this leading article in The Lancet, in which it was described as a new clinical entity. And the symptoms that these patients were experiencing were firstly severe fatigue, unrelieved by sleep, muscle pains, malaise with exercise beyond narrow limits, cognitive difficulties, spikes of fever, and hypersensitivity to sensory stimuli. These were normal environmental sensory stimuli of light and noise, and so this was an unusual situation to someone with expertise in infectious disease like myself. And I would point out that Dr. Ramsey was in fact my predecessor at the Royal Free Hospital by about 3 decades. And one of the interesting features of this particular feature was one sees it in people with acute meningitis as well. Someone who has acute meningitis and inflammation of the central nervous system as a result, they want to be in a nice quiet room with the curtains drawn, in much the same way that ME patients do. Now, having said that it's been called a new clinical entity, it's quite apparent that there have been similar outbreaks in Los Angeles in 1934, in Switzerland in 1937, in Iceland 1948, Australia 1949, New York 1950, London 1952 at the Middlesex Hospital. Now these are recorded outbreaks, so this may possibly be the tip of the iceberg. And the tip of that iceberg also probably conceals the fact that in addition to presenting as outbreaks, this disease also presents in endemic form with sporadic presentations of people in the community rather than in epidemic so-called outbreak form. Now, one of the major contentions over this condition is firstly what we call it. Dr. Ramsey first of all described it. He coined the term benign myalgic encephalomyelitis because these patients were suffering from myalgia, in other words muscle pain, hence the term myalgic. Encephalomyelitis, this showed a number of features of inflammation of the brain which were clinically evident to him. Now, there were a number of skeptics in the medical community at the time who decided, well, the term post-viral syndrome would be better because it doesn't necessarily indicate something with the specificity that this term does. So they decided on the term post-viral syndrome. But now post-viral syndrome is actually recognized as a separate entity. Chronic fatigue syndrome also was another term which was coined by some Americans in the 1980s. And then the term CFS ME is a sort of reversal of the term which is used now, ME-CFS, and this is now the approved term by NICE. All these other terms can be regarded as synonymous with ME-CFS. So in future, for the next few minutes, I'll talk about ME just to shorten the term. So the other contention that is ongoing and many of you will be painfully aware of it, is whether or not organic, i.e. scientifically identifiable pathology, is at the basis of this condition. In other words, has it got a physical basis, or is it due to psychological pathology? Is it due to psychological disorder with no evidence at all, apparently, to some people, of physical definable pathology? Now, physically definable pathology means a metabolic disturbance which can be identified by laboratory tests or, for that matter, evidence of inflammation in the brain, which can also be recognized using radiological techniques. So, I'm, over the next few minutes, going to dismantle this idea because the scientific evidence basically indicates quite unequivocally that there is scientifically identifiable pathology and this condition has a physical basis. The first indication that there is a physical problem can be illustrated by this diagram that I've drawn for you of the sort of thing that you see at the start of someone who gets ME, chronic fatigue syndrome. Now, the blue graph illustrates an immune response. This y-axis here of the graph indicates immunological activity, and the red graph illustrates what's happened when you get an infection of any kind, stimulating an immune response. Now, it's not only a great range of infections which can do this, and it's not just the viruses, but I've seen this happen with other infections such as giardiasis and also malaria. And in healthy people, the immune response to such an infection is an initial activity like this, followed by a downturn when the infecting agent is neutralized, and the immune response then shuts down, and there are no more symptoms. The point to make here is that immune responses do actually make you feel unwell, and that's why you feel unwell when you get an acute bout of the flu. Now, with ME patients, it would appear that something goes wrong with the immune response, and instead of actually shutting down in this normal fashion, the immune response actually seems to progress at a lower level. And the indication for this is the presence of an overactive immune system, which seems to be just not shutting down. And it's rather akin, the analogy here is a bit like a revolving door, where the door goes on revolving, but no one can get out because the door letting you out doesn't open. The other analogy for people of an older generation is for the vinyl record, which got stuck with a needle on one groove. And so this is what seems to happen with the immune system in such patients. And what goes on here has yet to be properly understood. But nonetheless, there is ample evidence that one of the underlying pathological features of ME is this ongoing immunological reactivity, which is inappropriate and makes you feel unwell. So, these are two books that Melvin Ramsey wrote about his experience of the royal free disease. This is edition 1, in which he was persuaded by his publishers to call it post-viral fatigue syndrome, because that was what it was still being called over in the United States, although he wanted to call it myalgic encephalomyelitis and post-viral fatigue states. But nonetheless, his publishers said, no, we've got to call it post-viral syndrome. So he was persuaded to do that. But when he produced the next edition, which was in the late 1980s, he was allowed to call it myalgic encephalomyelitis. Now, although the title of this talk is ME Past, Present and Future, I've found this book recently which I feel the title of which would serve as a very suitable alternative to the talk I'm giving. Never mind the bollocks, here's the science. And the author is Professor Luke O'Neill, who is actually professor of immunology here at Trinity College Dublin. And the curious thing about this theme that he's actually introduced with his title is that there is a tendency for human society to attach meaning and explanations to physical phenomena which don't necessarily hang together, but which nonetheless assume the status of dogma. And people hang on to that dogma until the underlying scientific cause can be properly identified. Probably, the very first example of this was Galileo, when he produced evidence, as far as he was concerned, on the basis of his observations with his telescope, that the Earth was by no means the centre of the universe, let alone the centre of the solar system. And he had a terrible time with the Catholic Church, who told him that he was wrong. And he had to retract what he'd said on pain of excommunication. So, and that particular problem has progressed throughout history. There was another remarkable example in the 1850s when cholera was epidemic in London from time to time. And a very perceptive young doctor called John Snow recognised that this cholera was being spread by drinking water and nothing else. And yet the prevailing idea at the time, which was basically dogma, was that cholera was the result of nasty smells called miasmata from rotting bodies and rotting vegetable matter. And John Snow produced his thesis as a result of walking from house to house to house, collecting all the data and putting it all together. And the result of this was his conclusion that cholera was spread by drinking water and not by miasmata. And the thesis he wrote actually stands the test of time scientifically now. And there's a copy of it in the Wellcome Museum in London as an example of a well-written and rational scientific thesis. Yet at the time, John Snow was put down by the Royal College of Physicians, who were a little bit snooty about it and said his theories are untenable. So anyway, the untenable theories have been properly dished by John Snow's thesis now. So if we go on. Now, I said that I'd talk about science and also at the same time about bollocks. And the first indication that the bollocks theory was actually alive and kicking in 1970 was evident from this article by McKevedy and Beard, two psychiatrists who actually went through the case notes of patients who had suffered from royal free disease. They didn't actually interview the patients, they just looked at their notes, nor did they interview any of the doctors involved. And anyway, the conclusion they reached was, from a reanalysis of the case notes of patients with royal free disease, it is concluded that there is little evidence of an organic disease affecting the central nervous system, and that epidemic hysteria is a much more likely explanation. The data which support this hypothesis are the high attack rate in females compared to males. Now, I know that will enrage at least half of you present, and this is actually nonsense. So that qualifies as bollocks. So this particular mindset, unfortunately, has been taken on by the medical profession even nowadays. And I do in fact see quite a few patients with this condition, and it's of interest to find out what they've been told by medical professionals previously. And I've collected some of the statements, some of the advice they've been given. It's all in your mind, forget about your body. You have an abnormal illness belief. Abnormal illness belief is one of the phrases which crops up commonly. If you're buried guilt, dig it out. You should get pregnant. Now, it's interesting. There is a slightly interesting aspect to this, because I've seen some young women with ME who do actually get pregnant, and interestingly, the symptoms of their disease do ameliorate, and some of them get better completely during the currency of their pregnancy. And the likely cause of this, again, is immunological, because, as most of you probably know, a pregnancy, to be tolerated by the mother's immune system, has to somehow cause the immune system to be modulated and to become less intolerant of foreign protein, foreign matter, which is basically, in technical terms, what a fetus is. And one of the unfortunate downsides of this is that pregnant women are in fact much more vulnerable to infectious diseases during the course of their pregnancy. The only death I've seen from chickenpox was in a pregnant woman in her mid-30s, precisely because of this vulnerability that the pregnancy has imposed in order for her fetus to be tolerated, but in turn that makes her more vulnerable to an infection like something very straightforward like chickenpox. My great-grandmother also died of tuberculosis soon after delivering my grandfather, because she also contracted tuberculosis during the pregnancy, but survived just well enough to deliver my grandfather, and then about 2 months later she was dead from her TB. So that fills in that a little bit. Go to the gym more often. Well, that's nonsense, and I'll tell you why later. Why do you feel the need to vomit? Well, that's a typical psychiatric question, and simply because many of the more severely affected ME patients tend to they feel nauseated much of the time, and in addition to nausea, they can't eat very much because they tend to vomit it up. And a psychiatrist involved with this particular lady felt that she had anorexia nervosa, and why do you feel the need to vomit was a sort of standard psychiatric question, which is absolute nonsense. You need more orgasms. Well, I won't elaborate more on that one. Let's go to the next slide. But anyway, that it, in addition, furthers the idea that this psychological dogma is nonsense. Now, just to digress a little bit, COVID, which obviously we know lots about now, causes long COVID in many patients, and long COVID is almost identical to ME, chronic fatigue syndrome. Now, George Monbiot, the well-known Guardian journalist, described his experience of long COVID in The Guardian. And then a well-known psychiatrist accused him of being a super spreader of long COVID simply by describing the condition in a Guardian article, which really was nonsense. But nonetheless, it gives you some insight into the mindset of some psychiatrists and how wide of the mark they are in understanding the organic nature of this disease. If I were to apply that logic to telling you people now what the symptoms of dysentery were, some of you might have to leave the room rather quickly in the next few minutes. But nonetheless, we do have psychiatrists who think like this, and it's one of the situations which I think needs to be altered and rectified, with a proper understanding of the physical basis of the disease. So, a bit of science. Well, Dr. Ramsey produced a small paper describing 10 patients in whom it was evident that there was a very high level of what's called myoglobin circulating. And these people had quite prominent muscle pains. And the myoglobin was leaking out of their muscles and was clearly a physical evidence of this problem, because the muscles were damaged, and myoglobin is a pigment which comes from muscles. So myoglobinuria was present in these people. It gave their urine a slightly reddish tint because it's rather closely related to hemoglobin. Now, there's yet more really good scientific description of the physical basis. Maddie Hornig is actually a psychiatrist working at Columbia University in New York, and she and her team looked at cerebrospinal fluid in patients with this condition, and their conclusion was our results indicate a markedly disturbed immune signature in the cerebrospinal fluid of cases that is consistent with immune activation in the central nervous system. So here is an example, a pathological example of why these patients can be called, can be regarded as qualifying for the label myalgic encephalomyelitis. The encephalomyelitis part of the label is adequately underscored by Dr. Hornig's findings here. So this is science. More science. This is a Japanese paper where they used a technique known as PET scanning to look at the brain and to look for areas of inflammation in the brain which weren't present in normal control patients, in other normal control volunteers. And they basically concluded that neuroinflammation is present in widespread brain areas in CFS ME patients. Remember, this is the same as ME-CFS, and was associated with the severity of neuropsychological symptoms. So more science. Right, let's plow on with the science. This is a thing called a bicycle ergometer. As you can see, it's basically an exercise bike, and the bodywork conceals a mechanism which measures the amount of energy being delivered through the pedals. And this chap is also wearing an oxygen mask through which the amount of oxygen he's taking on board is being very carefully measured. Now, the standard test for physical fitness, which is used in many areas, particularly, for example, in professional athletes who need to know how fit they are and also what training regime is making them fitter and so on. Standard test is to put a patient, so we put someone onto an exercise bike like this, and the instruction is to pedal to the point of exhaustion. And what you get is firstly a graph like this, indicating the amount of energy being delivered through the pedals. Okay, the amount of oxygen required to deliver that energy closely parallels that energy delivery. These are notional graphs, by the way. Now, there's a point which is reached here where oxygen delivery reaches a peak simply by virtue of the anatomical restriction imposed by the size of your arteries, the efficiency of your heart and your lungs. So the amount of oxygen which can be delivered to the muscles at peak exercise level is inevitably going to reach a peak like this. But the muscles do actually have a trick up their sleeves whereby they switch from a metabolic pathway which uses oxygen, the aerobic pathway, to a different pathway, the anaerobic pathway, and that allows the energy delivery to continue for about 15 and 20 seconds. But after that, what happens? is a sensation of exhaustion, means that the patient has got to, in fact, any subject has got to stop. And this here is known as the anaerobic threshold, the point at which the switch occurs from the aerobic pathway to the anaerobic pathway. Now, this is a sort of standard graph in a sort of person of standard good health. The likes of Mo Farah and all these top-class Olympic athletes, their anaerobic threshold won't be here. It'll be sort of up there. And that's why they can continue running and running and running without actually hitting this exhaustion threshold, unless they really do push themselves. Now, if you then take someone who's generally in normal physical health, and if you get them to sit around and for about 6 weeks and decondition them, and so that they become unfit in a sort of the general sense of the term, and you check their anaerobic threshold, and it's down here. Then if you get that same person and put them on the bike the next day and subject them to the same test, their anaerobic threshold will be up here. In other words, the exercise from day one has resulted in a slight improvement of their anaerobic threshold to day 2. However, if I take an ME patient and who is able to do this test on the bike on day 1, and you check their anaerobic threshold the next day, and it's down here. So this is where the advice to do graded exercise is so wrong, because it's very easy indeed for an ME patient to hit his or her anaerobic threshold. And the result is an immediate depression of the anaerobic threshold from a sort of moderate level down to an even less moderate level. And that's why patients with ME tend to have such a limited exercise tolerance. So this again is more science illustrating a metabolic disorder in patients with this condition. It's got nothing to do with psychological disorder. These are the papers which describe that phenomenon. This is a paper by Christopher Snell, and one of his conspirators, so to speak, was Mark Van Ness, who wrote this up. They discovered this tendency for the anaerobic threshold to be lowered on day 2. And Dr. Betsy Keller, again at Columbia University, discovered also the same thing. She repeated this study using different patients and different equipment, and demonstrated exactly the same phenomenon. Now, this study here was a study using muscle biopsies from patients with ME, and if you take a piece of muscle from someone and you keep it alive in the right solution, you can actually make that muscle twitch if you put an electric charge across it. And furthermore, you can make it twitch multiple times by putting multiple electric charges across it. But a patient with ME is likely, their muscle is likely to fade very quickly in comparison to a piece of muscle from a so-called control patient who's donated a piece of muscle to compare with the patient muscle. So here we have an example of a piece of muscle from an ME patient in a laboratory, behaving in the way you'd expect it to. That piece of muscle is well separate from the patient's psyche, safely excluding that possibility as an influence. So this is yet more science, indicating the scientific basis of this condition. Right. The American National Academy of Sciences Institute of Health has reviewed approximately 9,000 peer-reviewed studies into ME-CFS by 2015. And their report states very clearly that ME-CFS is a serious chronic and systemic illness that frequently dramatically limits the activities of affected patients. So these are some very eminent people in the United States reviewing thousands of papers and coming to the conclusion that psychology is not actually a feature in causing this illness, but there is clearly a physical basis to it. And the report is from the Institute of Medicine, Beyond Myalgic Encephalitis, Chronic Fatigue Syndrome, Redefining an Illness, Clinician's Guide, February 2015. More science. Right. So let's move back to the territory of bollocks. The PACE study. Many of you will know about the PACE study. It was designed to try and show that cognitive behavioral therapy and graded exercise therapy in particular were at least helpful, if not curative, in this condition. And they described their findings in the Lancet. That actually publication came out in 2011. Now, as soon as the publication came out, many patients really objected. Now, a very well-known psychiatrist actually added his approval to the PACE study findings by describing the PACE study. For those who appreciate these things, this trial is a thing of beauty. Well, let's just see if that's true or not. The Journal of Health Psychology, interestingly, produced a special issue on the PACE trial. And this is an excerpt from the editorial from this particular special issue. The PACE trial debate reveals deeply embedded differences between critics and investigators. It reveals an unwillingness of the co-principal investigators of the PACE trial to engage in authentic discussion and debate. It leads one to question the wisdom of such a large investment from the public purse. £5 million from the UK taxpayer went towards this study. And they describe it as a poorly done trial, and indeed it was. There were lots of flaws in the way the trial was carried out. We'll move on to that now. Firstly, only subjective measures of outcome were used. In other words, the patients themselves were required to provide a subjective account of how they felt and whether or not they felt that the treatment they'd received had improved them in any way. And the other really striking feature of the whole thing was that the patient's experience of this study, the people who were recruited into the study, their experience was at considerable variance with results of the study. Many patients I'd come across who participated in the study said, really, what was written up and officially described as the results of the study had no apparent relationship with my own experience of particularly with cognitive behavioral therapy and graded exercise. One or two other points to make. No one recruited to the study was able to return to their prior employment, which might be a good sort of yardstick as to whether they'd actually been helped in any way. There was actually an increased uptake of benefits amongst participants. And the other thing is that the investigators who were, because of the suspicion that there had been some jiggery-pokery going on, they initially refused access to the study data, and this had to be extracted from them by due legal process under freedom of information. And so clearly the PACE study has a lot of really rather nasty shadows cast over it. This is something I've taken from Monty Python, which basically indicates apparently many patients said they were coerced into giving the right answers when they were asked about cognitive behavioral therapy. And although this is possibly a slight exaggeration of what went on, it does necessarily indicate that there was some coercion involved in the process of obtaining from the patients their subjective views of how they'd done. Now, I've actually covered a bit of the history there, including addressing this issue of is it psychological or is it physical? And I think most of you will agree now that the scientific evidence in favour of it being physical is compelling. What about potential research avenues? Because clearly there's an awful lot yet to be done to find out about this condition. In my view, the immunological research avenue is probably going to be the most fruitful. Genomic studies looking at the potential hereditary vulnerability of some people may well throw up a few interesting examples of what's going on. Virological studies probably are going to be less revealing in terms of the ultimate body of knowledge contribution that's made by the researchers. I think that immunology is going to be much more revealing eventually when more is discovered along those lines. Finally, it's just worthwhile just referring to the treatments, which are sometimes of help in patients, although we don't know the cause and we don't have the magic bullet yet, which is going to make you better. There are certain physiological abnormalities which are detectable and which can be treated. The first physiological abnormality is reduced blood volume, and the causes of that in most patients are low cortisol levels. There are probably other endocrinological causes which cause this reduced blood volume. And one of the features I see in most patients when they come and see me is that they're always thirsty, and they tend to bring a bottle of water with them and put it on the desk in front of them. And when I ask them, what's the water for? They say, well, I'm always a bit thirsty. Do you then pass lots of urine? And the answer is often yes. I often have to go and pass urine frequently. And so what's happening here is that the mechanisms which maintain blood volume are not working properly. The kidneys are losing salt and water mainly, and so these patients tend to drink additional water because they feel thirsty all the time. A reduced circulating blood volume is always going to make you feel thirsty. And the treatment here is additional salt intake. The best form of that is as glucose electrolyte solution, which you can get over the counter in the form of diarrholite from a chemist. Intravenous saline is often very helpful in some patients who are very sick. And midodrine for POTS, postural orthostatic tachycardia syndrome, is also helpful, because the other reason why people get postural orthostatic tachycardia syndrome is that the reflexes which normally function appropriately when you change posture from lying flat to standing up don't function well enough, and you get pooling of the blood in the large veins in the legs. And the midodrine helps these veins and other blood vessels to contract and prevent this pooling, or at least to ameliorate it to some extent. The next thing, which is sometimes amenable to treatment, is mast cell activation. Mast cell activation in many ME patients causes digestive symptoms, which is basically the result of a sensitivity to various otherwise harmless items in food. And the sensitivity can sometimes result in release of histamine from mast cells lining the gut. And the result is often quite severe abdominal pain and vomiting. I take you back to that question from the psychiatrist. Why do you feel the need to vomit? Well, possibly it was the mast cells which replied to the psychiatrist and not the patient. But anyway, The other thing that these patients get is, as well as the abdominal symptoms and abdominal pain, they can get quite severe hives and a very itchy skin after they've eaten the offending substance, which causes the mast cells to be activated. Treatment which is sometimes very effective is sodium chromoglycate. The trade name for that is Nalprom. Antihistamines are sometimes helpful as well, and in severely affected patients, nasogastric feeds are often necessary because these patients are often so weak they just can't swallow. They don't have the muscular stamina to chew or swallow food, so they need to be tube fed. And one of the issues that we've discovered recently is you've got to give this tube feed at body temperature. A tube feed which is cool and sort of hits the lining of the gut at a temperature significantly lower body temperature is again going to cause these mast cells to activate. So you need to be sure that the nasogastric feed is actually body temperature. Moving on to neuropathic pain. This is one of the really difficult problems that I see from time to time, and there are various approaches which are useful. Gabapentin is helpful in some patients. One of the relatives of gabapentin is pregabalin. Some patients also derive benefit from taking cannabis oil derivatives. And one of the clues I fastened onto some time ago was actually provided for me by a couple of patients who said the only thing which makes my generalized body pain work a bit better was smoking a joint. And so smoking cannabis seemed to be helping the body pain that these patients were suffering from, hence the advice to take CBD derivatives. Lignocaine infusion is another approach which is actually quite widely used in various NHS trusts. What you basically have is you go into hospital and you have an infusion of lignocaine, which is a local anesthetic, and that seems to shut off much of the pain, and it's very effective in some patients for up to 2 or 3 months, and it's often used for other chronic pain syndromes as well. Finally, there is this vexed question of B12 injections. B12 injections are basically harmless, even in very high dose. And the thing about vitamin B12 in high dose is that it's actually used for patients with acute cyanide poisoning, which is not a common problem, but arises occasionally in patients working in industrial chemical labs. And one of the standard approaches to treating cyanide poisoning is using a very high dose of B12, and multiple episodes of this nature have shown that B12 doesn't harm anyone. One of the mistakes that many GPs I've discovered make is that they think, well, because the serum B12 is normal in my patient, why do they need B12 injections? Well, the explanation here is that the B12, when it's injected, seems to have an additional function in that it neutralizes a lot of the immunological byproducts of inflammation, of this low-grade immune activity. And from a clinical point of view, I have a number of patients who say the B12 injections may have made a big difference for them. And so that's another approach which can be used. Just to recap on this slide, clearly there's no magic bullet yet, but nonetheless there are physiological abnormalities which are the result of the pathology of this condition, which can be treated. And I've given you a resume of those here. Right, well, we're nearly the end of my talk, and what I want to do is basically summarize by saying there's clearly much to be learned still. Organic research needs more funding, and the psychological paradigm really has to be buried. The idea that this is a condition which has a psychological basis really is nonsense, and I'm rather worried by the fact that there is a sort of a growing cabal of characters who still seem to think that it is basically a psychological disorder, and furthermore that long COVID has a psychological basis, but it doesn't. Anyway, so this really encapsulates what needs to be done, and I'm actually quite optimistic that probably within about 5 years we're going to actually have the magic bullet, but it's going to take a lot of research and probably a lot of research money before that's achieved. Thank you very much.
Hi, I'm just wondering about gabapentin, and Neurontin is the name of the one. It's the same thing, I think. I take very high doses of that for the last few years, and very high doses of amitriptyline, and I know they're high because the pharmacist always asks me if I should be on that high a dose. Now, it has made a big difference on like some quality of life, but I just wondered whether there's any research or anecdotal evidence on the long-term effect of staying on that those daily for.
The question illustrates concern about long-term amitriptyline and also the gabapentin, which I understand you're taking. There's no evidence at all that long-term amitriptyline will damage you in any way. It doesn't seem to result in dependency of any kind, unlike some of the other psychotropic medications. And furthermore, gabapentin also has been used long-term in other conditions such as diabetic neuropathy without any particular problem.
Thank you so much for the presentation. I'm a carer, I'm not a sufferer. I've been a carer for my wife for about 13 years. I have 3 questions, and they probably will be relevant to people who have tried things as well. These are from her, by the way, she's at home. Any pointers on how to get a diagnosis in Ireland, since our GP is technically a dead end? I don't think that's news to many people here. The second question, what treatment and support can you request from your GP, who has been aware of her symptoms for many years, and more than 10 years, if you only self-diagnose at this point? So what we're talking about here is that we know the saline IV and the B12 intravenous helps, and also vitamin cocktails, but she's housebound. So maybe someone in the organization already got experience with how do you get an IV at home, which seems to be something that would help, but you can't get, and going to emergency kind of ruins the risk reward of the attention. The last question, same for physiotherapy. What adjustments are required, since physical exertion makes it worse, like the post-fatigue syndrome? And are there ME-CFS informed therapists that somebody might have come across who wouldn't try the same manipulations they would try for someone with a better health state? Thank you so much. Much appreciated.
To answer your first question, it's clear to me that both in the UK and in Ireland there's a fault line which runs through the medical profession, on one side of which are people who still think that this condition has a psychological basis, and they're actually at the same time unwilling to actually provide you with the correct diagnostic label. They'll go into all sorts of get on all sorts of avenues, like, were you treated well as a child, and why do you have the need to vomit, and things like that. All these rather completely off-beam questions which indicate that these medical professionals don't really seem to have grasped the idea that this condition has a physical basis, and they haven't done their homework properly. Now, it occurs to me that obviously the same situation exists here in Ireland as in the UK, it is, it's a really bizarre situation. I don't understand why a condition like this, which has clear evidence of a scientific basis, and for which there's no evidence that a psychological basis exists, there's still people who cling to the dogma that the psychological basis is the way forward, and treatment for it is the way forward, which is nonsense. I think your second question was about treatment.
What you do when you're housebound? Like, is there a process to ask for IV, for example?
Yeah.
Being housebound, you're put in a, my wife couldn't join us today because she's in a very bad episode. So, what type of service? My thinking had been a while back that palliative care provided at home has some similar parallels, like making the sufferer.
Just to try and answer that second question in brief, I know there are other people who want to ask questions as well, but the housebound people belong to a group that we've actually labelled as the 25% ME group. These are the people who are housebound, and sometimes even bedbound. And the standard of care that's available for them from the UK National Health Service is abysmal. And I've mentioned intravenous saline. It's usually only possible within the protocols and guidelines of the NHS to give people intravenous saline in hospital. And I have spent a lot of my time trying to persuade the hospitals to leave the intravenous line in so that these patients can continue to receive their intravenous saline, which has obviously helped them enormously. But that doesn't happen necessarily. I mean, what you've touched on here is a problem for which I unfortunately don't necessarily have a solution.
Anything on the physical therapy that you think?
Yeah. As far as physical therapy is concerned, I did actually. Oops. No, sorry. I showed you that graph of the anaerobic threshold. The mistake that a lot of people make is to impose an exercise regime on people where they push themselves to the anaerobic threshold, and that inevitably makes them worse. And the interpretation that sometimes applied to that, extraordinarily, is that these people, they must have a psychiatric condition because they should know that exercise is going to make them better, and they're being perverse by avoiding further exercise. And it's a sort of dogma that has clearly got to be removed from the whole panoply of medical care, and we're simply at the early stages yet.
Thank you so much.
Thanks. So I know the aim is to avoid getting to a post-exertional malaise state, but once you're there, any suggestions? In my case, I get particularly bad headaches. I just haven't found anything that helps with that yet. So obviously I rest, but is there anything beyond that?
There's a very well-known biochemist in the United States called Ron Davis, and he runs a biochemistry lab in Stanford University. And his son is very badly affected, which gives him a personal reason to look more carefully at this condition. And an anecdote which came out of his lab recently was that of a young female research assistant whom he regarded as a very good person to have on the team, so to speak. But she got ME, and she disappeared for 18 months. And she returned after 18 months or so, fully recovered. And when asked what it was that made her better, she said, I avoided crashes. And what she was doing was, I tried to get that graph up again actually, showing you the anaerobic threshold stuff. But what you need to do is avoid crashes. Know when a crash is imminent, and what you do then is you rest. And one of the phrases she apparently sort of came up with frequently when describing her disease, the course of her disease, was rest, rest, rest. And this is in complete contradistinction to what has been the case in conventional circles in NHS in respect of graded exercise therapy. And a lot of people around the country, in the UK at least, have actually been damaged by graded exercise therapy. And the reasons are pretty blindingly obvious now. But it's quite apparent that rest, 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 avoidance of crashes is the way to get better, but it's going to be a slow progress.
Can I ask, has anybody researched about the hormones women in premenopause? I found that I suffered terribly with my skin. So it broke out all on my face, on my scalp. I was in a terrible condition.
So what broke out in your skin?
Skin, it's like they still don't know what it is. It's, I just keep breaking out in blotches all around. Yeah. All on my scalp, all on my face, especially under my eyes, around my mouth, my nose.
Yeah.
But when I started a HRT 5 years ago, it completely disappeared. Within 3-4 weeks, it was completely gone and completely disappeared. But over the last 8 months now, it's starting to come back, but I feel like I'm on my way into menopause. So I'm just wondering, has anybody researched about what the estrogen level or progesterone level of women going into early menopause? Would that have some effect on your symptoms?
I think what you described may well have been a manifestation of mast cell activation. Was this quite itchy? This?
Oh well, absolutely. I nearly
Yeah.
and I never had issues with my skin till I got ME, and that started. It started with a little small patch, and then over the years it got worse and worse.
Yeah.
And my dermatologist, she tried everything.
Yeah. I think basically, and I'll basically shorten my advice because I know that other people will be wanting to ask questions, but what you should probably do is get some antihistamines.
I'm on antihistamines.
Which antihistamine are you on?
Level something. So I have it on my
Right.
I'll get you go to but it's only 5 mils. I've asked about upping because my skin is constantly itchy.
Other antihistamines you can try,
Right.
which might actually have a better individual effect. But
Right.
certainly around the menopause, one does see patients sometimes getting worse with their ME, and paradoxically sometimes getting better. It's a very sort of paradoxical and rather quirky.
Well, this pushed me into early menopause. I was 38 when I got ME, and I went straight into, so I've been in it for 15 years.
Yeah.
So I'm just wondering have they looked at the progesterone? So I was just wondering because I feel that over the last few months that it's getting worse. Also, like the inflammation is getting worse and the itchiness and.
I've been advised not to turn this session into a private consultation.
No, I just wonder was there research on?
No, I think what sounds like is that you do need to try out the various different antihistamines.
Yeah.
And that's the next route to go down.
Right. No, it's just my doctor won't do it.
Hi, what's your view on LDN, low-dose naltrexone, as a treatment?
Low-dose naltrexone is seemingly effective in some people but not others. And there's no predicting who's going to benefit. And really the only thing to do is just to try it and see what happens. Basically what it seems to do is it shuts down that part of the immune system which is overactive and shouldn't be overactive. That's the theory anyway, but the practice is different insofar as some people benefit, some people don't.
Hello, my son is 27. He got COVID in March 2020, and he hasn't got better, and he's got worse, and he's reached the stage where he's completely bedbound and using all his energy to have one meal a day. We don't want him to get worse. Where do we start? What can we do?
Clearly he needs to be sort of seen by someone with expertise in this area, and on the basis of your description of him, I can't really give you the advice that he probably deserves and needs, but essentially what he does need to do is rest as much as possible, and you need to keep him hydrated and well nourished if you can.
Hey, I was just wondering, what do you think of the relationship between long COVID and ME? Do you think they're the same disorder or similar disorders, or something different?
I think long COVID is almost identical to ME in terms of its basic pathology. There are one or two slight differences in the clinical manifestation one sees in some patients. For example, about a year ago I saw a woman in her 40s who obviously had long COVID because she developed COVID infection and didn't get better, and she had all the features one expects to see of long COVID, which are so similar to ME it's difficult not to assume that they are identical. But one of the features she had was pain in her right arm and tingling in her hand, which was of interest because she'd been to see her GP who hadn't actually examined her, and she'd also been sent to a cardiologist who didn't examine her either. But when I saw her, I thought, well, I'm going to look at this arm, and I felt the pulse on the right-hand side and the pulse on the left, and there was a huge difference. And what she had was a blood clot in the subclavian artery, blocking the blood supply to her right arm. Not completely, but certainly partially. And she had to have it removed. But that's an illustration of how long COVID can probably be slightly different, because COVID has this tendency to cause vascular thrombosis more so than the other causes of ME.
You okay to take another couple?
Sorry?
Are you okay to take another couple of questions?
Two more questions.
Two more questions.
Thanks,
There's
Dr.
a lady here,
Weir.
actually, who's been holding a hand up.
Just me, sorry.
Yeah.
I was just checking if you've any experience of treating patients with vaccine-induced long COVID.
Sorry?
I'm just wondering if you've any experience of treating patients with vaccine-induced long COVID. Any histories, any outcomes, or any experiences from that?
It's acute COVID tends to be the situation where you get vascular thromboses, and people suffer from strokes, they suffer from deep venous thrombosis. It was unusual to see this lady with a vascular problem in her.
No, I mentioned it's vaccine-induced long COVID. Vaccine, from the vaccine.
Vaccine.
Sorry.
The long COVID vaccine has attracted a lot of criticism recently because it's now evident that it causes a fair bit in the way of side effects which are unanticipated. And in my view, the idea of giving COVID vaccine to people with long COVID is the wrong idea, because what you're doing is stimulating that immune response which is generating the pathology in the first place, and I think it's a bad idea.
So, okay.
This lady here, I think she'd better be the last one.
I've had ME for 7 years and severely affected. My question relates to genetics. My 16-year-old daughter was diagnosed with ME last Friday.
Diagnosed with?
ME.
Yes.
My question is, from your experience and from research, do children tend to follow the same severity and symptoms? And my other question is, for my daughter, she wants to ask, what are her children's chances of getting ME?
I'm sorry, I haven't really understood much of that because your voice is a little bit faint. And what you seem to be asking is whether or not there is a recognisable hereditary link between patients who get ME and
the
vice
symptom
versa.
severity tends to follow on, so do people when there's a familial link, do they, the person infected, do they tend to follow that same symptom severity and system being affected?
One of the things I should say is that there is actually a rather unusual, very unusual hereditary condition where the mitochondria are dysfunctional, and mitochondria have a strip of DNA in them which governs their function, and that strip of DNA is handed down the female line, and so-called mitochondrial disease can manifest in all sorts of ways. One of the ways is rather similar to ME, but it usually presents in early childhood, and so on that basis it can be identified separately from ME as such. But you need to have a special test, you need muscle biopsies to look for this damaged mitochondria. Okay, well I think that's probably enough for the evening. Many of you will be wanting to get home to your beds, but I hope that I've at least enlightened you, some of you, and given you some faith in the future of the of this condition, and I want you to go away with the understanding that science will actually tell us what's going on probably in about 5 years' time. And by that time we should have a decent treatment.